Good evening, everyone. Thank you so much for joining us this evening. My name is Esther Dawkins. I am the coordinator of the Clinical Service Improvement Program, and I work with the Institute for Health Leadership in the Department of Health. I'm really excited to be here today to talk to you about the 2021 Clinical Service Improvement Program. Some of you may be aware, over the past 8 years or so, we've been running the Medical Service Improvement Program. And in 2021, it's the first year that we're expanding that program to launch a new program, which is open now to nursing and midwifery, allied health, medical, and medical staff. So it's a really broad, expanded program, and we're really excited that we've been able to do this going into the 9th year. So today I want to talk a bit about the program and give you some specifics on how to apply, give you a bit more background of what exactly the program entails, and I'll also go a bit into what the Institute for Health Leadership provides. We have been running the program since its inception and have been around since about 2007, but we'll go into that a bit further. So today, as I just said, there's an introduction to the IHL and our range of programs, and also into leadership at that strategic sort of system level. I'll then talk about engaging in service improvement and why it is so important as a system that we engage clinicians in service improvement, clinicians right from early career through to that senior executive level. We'll also go through some specifics of the program itself. Then we're lucky to hear from 2 previous participants of the Medical Service Improvement Program who'll tell you a bit about their projects, but then also about their experience on the program, some of the things that they have learned and their, I guess, reflections on sort of where they see it taking them or where it has taken them. So we're hearing from Isabel, and Izzy did her project this year at Midland, and we're also hearing from Seb. So Seb did his project last year at Royal Perth. And then I'll round out the evening by letting you know how to apply for the program. So the Institute for Health Leadership, as I said, was established in 2007. It was established to build the leadership capacity and capability of staff across the system, whether that be clinical staff, non-clinical staff, from all health service providers, from all hospitals, from all areas in our very large system. We also want to act as a resource and research centre for leadership development. So we want to bring you the contemporary leadership research and provide you with a national, state, national and international perspective on what is happening in the space of leadership development. Our aim is to ensure that we have excellent leaders at all levels of the health service. Often we think of leadership as being a role or a position that you really only attain later in your career. That's not what the Institute for Health Leadership thinks of when we talk about leadership. We think of leadership as a set of behaviours, and they're a set of behaviours that you can use right now, no matter where you are in your career, whether that be interacting with patients, leading and engaging a team, or even outside of work. So we really want to deliver and develop our people in our system to have those excellent leadership skills early in their career, so you can take that through your career, and when you get into those leadership roles, you don't have to backtrack and sort of develop those skills on the job. You've already got them. You can step into those roles and really make them your own, and really bring those already well-honed skills. We also are wanting to promote leadership as a key determinant of health and a key determinant of a culture of continuous improvement. We know that organisations with poor leadership, and poor leadership at all levels, have worse health outcomes. We've seen it all over the world, and so what we want to do is upskill, make sure our staff, develop our staff, and make sure that they have sort of the best leadership skills they can, and therefore delivering the best care that they can deliver to the patient. In 2019, the Institute developed the WA Health Leadership Strategic Intent. And that strategic intent was designed to be a high-level, system-wide perspective on what we as a system need in the space of leadership and leadership development. If you haven't read it, or if you have never heard of it, go to our website, and it's on our website. It's on our Health Point page, sorry, not our website. It's on our Health Point page, and that's under the Department of Health, green Health Point page. So you'll see it there. Off the back of the strategic intent, the IHL developed a framework for programs that would meet the needs of that strategic intent and meet the needs of our staff. So you can see here a framework for leadership development programs and leadership development initiatives that the IHL will start to roll out the beginning of next year. You can see here I've circled the Clinical Service Improvement Program as one, and that sits under what we say the influencer level. So that's early career leaders, people like yourselves who haven't necessarily done a leadership role before or aren't in a leadership role. You're on the ground, you're delivering patient care. So that's who we're talking about when we say influencer. And we've got a number of other programs for different sort of target groups or staffing groups across the system. So our graduate program for non-clinical staff, our Emerging Aboriginal Leaders program for our Indigenous leaders, and our Clinical Leadership Advisor. So that's a leadership role that sits with us at the Institute. And then we have our Leader Coach. Leader Coach, that level is more your middle management level, and we have a number of programs at that level. And then we have our Strategic Leader level, and that's for your more hospital executive, high executive leadership group. And you can see here we've got programs that sort of target each group, but we've also got programs that span across, and that's because we really believe, and research and best practice believes, that we should be developing people in a collaborative leadership model. So what I mean by that is it's not discipline specific, it's not level specific. We really want to bring people together who are delivering patient care at every level from every discipline, so they can learn from one another and they can develop together. So what is the why of MSI? Why do we run this program, and why has it been so successful over the past 8 years in the Medical Service Improvement Program format? Well, why we do it is that we want to engage clinical staff in reform and service improvement. We know that if clinical staff are engaged in this area, health outcomes are going to be improved. And it's going to be a much more functional system and organisation to work in. We want to empower clinical staff to redesign elements of their health system. So you guys are there and you are often the recipients of changes, of new forms, of new processes, and you may not have actually been consulted about them. I'm sure you can think of a number of times where you're expected to do something differently or implement a new system, take part in, a new process, and you question why you're doing it or where it even came from. Well, we don't want that. And the reason this program is so powerful is because you actually are the ones that see the issues in the system on a daily basis, and we're giving you the skills and we're actually giving you the time to engage and lead change for the areas that you see and you're passionate about. And so you aren't the recipients of change, you're the drivers of change. What we also want to do, and we have done quite successfully over the past 8 years with over 200 junior doctors going through the Medical Service Improvement Program, but now even more so, we want to develop a network of clinicians across levels, across disciplines, with a functional proficiency in service improvement, but also that speak the same language around leadership and leadership development. it's really, you know, you don't want to be that lone person who wants to make a difference. You want to be surrounded by people that understand where you're coming from, that understand and have the skills that you have, so you can collaborate and work together on leading change. This program also is beneficial for the hospital, as it enables them to identify areas that they may not necessarily always see, and register issues and workflow problems and process issues within their organisation, and then have someone dedicated who is clinical, who knows the intricacies of the clinical processes, and who is then able to lead that change. So it's a really powerful tool for the organisations, and that's why we have, every year we have more hospitals, more health services coming on board saying, I want to be involved. And when we expanded this program this year, we initially started with a pilot target group of hospitals, but then had to keep expanding because we had people saying, well, we want to come on board, we want to come on board. So it's really exciting that your hospitals will actually support you to have the time to do this. The Clinical Service Improvement Program framework was designed around the the Health Leads framework. The Health Leads framework is a national framework for leadership capability development. It's also used in many developed countries across the world. So Canada use it, the UK use it, and they call it slightly different things, but it is essentially the same capability framework. So what we mean by this is our program is designed to follow these sort of steps. We develop you and we provide you with professional development in the space of leading self. You can't think about leading others, leading teams, leading organisations unless you understand and have some insight into your own behaviours and how you impact the world. And once you've understood that and you've worked on communication skills and all of that, or just honed the brilliant skills you may already have, then you could think about, okay, well then how do I lead and influence teams? How do I lead and influence the organisation? Once you've got those skills and you understand that, then it's about looking at achieving outcomes and driving innovation. And finally, what this program really is beneficial for, and what we really try and encourage you to do, is take a step back and look at the system, get a system perspective. And what I mean by that is you are often in quite transactional task sort of completion mode when you're at work. This gives you the time and the space to sit back, and you almost have to look at all the different areas of the organisation that sort of sit behind the clinical coalface that make the system run. So that might be policy, that might be planning, that could be sort of your hospital executive or your health service executive, or even the Department of Health and what we do there. So it's about getting that understanding of where you and what your decisions that you make impact the greater organisation and how the greater organisation's decisions impact you. So that's something that our participants reflect on that's quite beneficial about this program. You see here the health leadership vision, and the reason we developed this is that we really wanted some sort of vision of what type of leaders we want in our organisation that meet sort of the best research and best practice for, you know, internationally what it says our contemporary leaders should be. We are working, and especially this year, have been working in what we call a VUCA environment. So VUCA stands for volatile, uncertain, complex, and I can't remember the last word. Anyway, you get the gist of it. So we are working in this environment, and we need to therefore make decisions in an uncertain setting. We may never have the full picture, or we may need to make decisions very quickly, and we've seen that with COVID. So we need courageous leaders. We need people who are willing to make those calls. Often when we see people in organisations that are unhappy or that don't sort of enjoy the work they do, a lot of the time it's because their values don't align with the values of the organisation or the values of the work that you're being asked to do. So what we really want to do is strengthen our leaders' strengthen our leaders' sense of value and ensure that you're working in accordance with those values. So you're working aligned to your values. Collaborative, the whole purpose of expanding this program was for this exact reason. We don't work in silos, so why do we develop ourselves in silos? We need leaders who are willing to collaborate and are willing to break down the silos that we see, whether those silos are discipline silos, organisational, hospital silos, health service silos, etc. So community, primary care silos, there's so many that we see. We really need to break that down, because at the end of the day, the patient's journey through the health system isn't siloed. They move from one silo to another, and we need to be able to move with them. And we need a system focus. I said this before, the ability to sit back and understand how our decisions impact the greater system. So some program specifics, and probably what you're here tonight to sort of hear more about. This program enables you or offers you the opportunity to have a dedicated 10 to 13 week rotation or part-time equivalent, so part-time over, say, 21 weeks, to work solely on a clinical service improvement program. This program is open, depending on site, to allied health, nursing, midwifery, RMOs and registrars. During this program, you will have, as I said, that dedicated time to do a project. And what we do is we provide you with a whole range of support and a methodology to work through that project. We support you in selecting a project at the start, in line with also your hospital and what your hospital strategic sort of objectives are. We provide you a clinical supervisor. So that's someone generally that's working in the area your project is being undertaken in. We provide you a service improvement supervisor. So that's generally a person who has project experience, change management experience that works in your site, and an executive sponsor. So the executive sponsor is someone who's senior, who has influence and sort of can act as your executive champion on this project. And you'll see here this framework. This will become your sort of Bible working through this rotation. We deliver training on the framework and all the actions and all the steps and deliverables at each stage of this framework. So the framework is called the Clinical Service Redesign Methodology, using the DMAIC framework. So DMAIC stands for Define, Measure, Analyse, Improve and Control. You can see these outer rings of project management, risk and change management, stakeholder consultation, including patient, staff and organisational consultation, and governance and leadership. And the reason these are outer rings is because they really come into play during all phases of the program, all phases of your project. So the DMAIC methodology gets you to define the problem, map it out, find out really what you're dealing with here, and identifying all the possible issues that are occurring in your process. You then go away and you collect a whole range of data to measure some of these issues and how big of a problem they actually are. Then what we do is we analyse those problems. So if you think of an issue that you're seeing, long wait times, for example, as being the weed or on the top, on the surface, or the symptom, what we do in analyse is actually find out what is the root of that weed or of that symptom. What's the main driving cause of it? So what we do is root cause analysis, and we really break it down. We keep asking why is that happening, until we've got to the bottom of the problem. Then once we've done that, we can develop solutions that are specifically targeted at solving that problem. Instead of saying, here's an issue, I think I know how to fix it, implementing a solution, and then the solution failing because we haven't actually got to the bottom of the problem. Our solution's fixing the symptom with the Band-Aid, it's not actually fixing the root cause. So this methodology is really great in that it enables you to dig down and find out sort of more about it. Then we look into improve and control. That's where that's where we develop the issues and we develop the solutions and implement the solutions. It's based on Lean and Six Sigma, which are two internationally renowned sort of change and management methodologies, and they are, the idea of Lean and Six Sigma is to reduce variation, reduce error rates, and standardise processes. And we adopted this methodology back in 2007 and tailored it to the WA health context. You'll see this same methodology across Australia and also internationally. In various, they might call it something different, but essentially it's exactly the same thing. So it is a very well-established methodology. So you will get training in this, and by the end of it, you will have worked through this whole process with a lot of support. So who's participating? Who's offering rotations next year? So for nursing, midwifery and allied health, the sites that are offering rotations for your disciplines are Bunbury Regional Hospital, Child and Adolescent Health Service, including Community Health, Royal Perth Bentley Group, and for allied health that includes Armidale, Sir Charles Gardner Hospital and Osborne Park Group, and Women and Newborn Health Service. If you're medical, you will be supported to do the program at Albany, Broome, Bunbury, Fiona Stanley, Geraldton, King Edward, PCH, Rockingham, Royal Perth Bentley Group, Charles Gardner Hospital and St John of God Midland. And if you're a registrar, you can also do the program at St John of God Midland. So this is a bit of an overview of the rotations for next year. It's quite messy because we're still confirming exact rotations at some of the sites. But what you can see here is the rotations aligned to our junior doctor RMO dates. This is for, I guess, simplicity to make sure that everyone starts at the same time. And what this does also is it enables you as a cohort of participants to work through the program together, to meet challenges at the same time, to bounce ideas off one another, because you're all sort of experiencing the same issues and the same challenges and the same sort of achievements at the same time. So if you're nursing and allied health, nursing midwifery or allied health, then you will start and end at the same time. What you can see here is that some sites, for example, Child and Adolescent Health Service, are doing one FTE at 0.4 over 21 weeks, or so two 0.4s over 21 weeks, as you can see there. And so you get longer, you'll get the same amount of time just stretched out further. So you'll do part of your time on the program and part of your time clinically over those 21 weeks. What we see at the bottom is Midland and PCH junior doctor terms are slightly offset the dates from other sites, and that has been the case for a long time. So we just sort of put them, you just start at slightly different times, but you will still be involved in all the training with the other participants. So what you can see here is some past project themes. So what type of projects will you do, and what opportunities will you get to maybe do projects that you're passionate about? Projects that suit this program are maybe projects where there's an issue that there's no simple solution to. So it's not like, here's the problem, here's what's going to fix it, and all I need to do is implement it. It's, here's the problem, there are potentially many, many reasons why this is happening. There's no clear solution for it as yet. So we need to work through, we need to find out our root causes, develop our solution ideas, and then implement something. So if you've identified something in your organisation that really frustrates you, or you've been wanting to get your teeth into for a while, this is a great opportunity to do that. So some examples of past projects, the We Need to Talk project, that was a clinical debriefing project after a clinical incident, so both hot and cold debriefing at King Edward Hospital. We have the Voice Your Choice project from Royal Perth that was done last year about goals of care communication. We have the CASPA, so the Cataract Surgical Pathway Review project from Fremantle Hospital. Race 48, which was responding to acute cerebrovascular events in the first 48 hours at Fiona Stanley, and the Little Lungs Clear Futures project. So that was at PCH, and that was looking at smoking cessation for families and carers. So what you can see here is not only do they have really awesome logos, and you'll get to sort of brand your project as well, they are very diverse projects. So you've got projects in the wellbeing space, staff wellbeing, patient communication, through to very clinical projects such as the cerebrovascular Race 48 project, and then more public health, preventative health projects such as the smoking cessation project. So it's quite exciting, and the sky's the limit when it comes to what you can do. As I said before, you have got a great support structure. We're not just going to put you in the rotation and say, go and have fun. We're really going to support you and help work your way through this. So if you've never done anything in the project space before, that's fine. That's great. We want to be able to provide you with those skills. So there's me, and I will provide you with, I'll coordinate the program. So coordinate the training, deliver the training, and also just be there if you want to catch up for a coffee and, debrief about challenges you're facing. You'll have a clinical supervisor. So your clinical supervisor, as I said before, is someone in the clinical area where you are undertaking your project. You've also got a project supervisor. So your project supervisor is someone who's an expert in project management, change management, and they can sort of help you with all the little things like how to book a meeting room, how to facilitate a session, that sort of thing. Your exec sponsor is someone at your site who is really who's senior and able to really back your projects. Your clinical advisor is someone that sits with us at the Institute for Health Leadership. They're a junior clinician. They're someone who's potentially done the program before or worked in this area, and they are able to provide you with support, mentoring. If you want to have a chat and you're really frustrated about something and you just need to vent, they're there to help you with that. You've got your program participants as well. So as I said before, you all meet challenges and you work through it at the same time. Previous participants of the MSI program will tell you that those colleagues really provide a really, really great support network through the program. And finally, we'll give you a buddy. So your buddy is someone who's done the MSI program before, and so they will be able to give you tips and tricks specific to your hospital. So just briefly, because I feel like I've covered a lot of this, some of the benefits of the program. So for participants, there's some great professional development. You get to develop yourself as a leader, as well as getting the service improvement skills. It's great, looks great on your CV. We don't want that to be the only reason you apply. We really want you to be, driven to improve your service for the patient and for the hospital you're working in. But it does look good on the CV, and it is something a little different that maybe a lot of your colleagues haven't done. It helps you clarify career objectives. So if you sort of don't know where you want to take your career, or you may sort of have a number of avenues you're tossing up, it gives you some time maybe to sit back and look at those avenues and really have some thinking time about what you want to do and sort of where you might go into next. And it gives you that system perspective of the hospital and of your organisation, greater organisation. For the organisation, it's an opportunity for knowledge transfer of improvements. So what I mean by that is you've got the eyes on the floor. It's an opportunity for them to sort of grab those ideas and really bring them to fruition and improve the care and the services that they deliver. It's good also to develop a cohort of their staff that have clinical leadership skills, that have clinical service improvement skills. And so, you know, for forward planning of people for leadership development and leadership roles, it's really great for them to have a really strong group in their organisation. And for the patient, it is, you are improving the care you deliver to them. So improved health outcomes, better access to high quality care, and also an improved dialogue between you as the clinician and the patient. You know, we really try and develop and bring your communication skills out and develop you as a leader, so that, you know, when you're interacting with patients, you know, you're doing it the best you can. So I've talked about this service improvement training in the DMATE methodology. This is what the training looks like across the term. So initially you get 2 days face-to-face training. For our country participants, we've got online learning that we deliver, that we also back up with a lot of video calls and things like that to make sure you're tracking okay. We then have data analysis training. So we sort of work you through how to use Excel, how to analyze data, how to approach data, how to know what to measure in the first place. We have a mid-project training and mid-project presentations and end project presentations. So what that is the training is just the end of the methodology, so the last 2 phases, and then you'll present. So you'll present your project at the midpoint of your project and your final presentation at the end. And you'll present that to a group of stakeholders from across the system, who sort of may be supporting your projects, maybe supporting others' projects, but also, you know, everyone from chief executives, assistant director generals, right through to your key stakeholders, your key people who are working on your project in the area, you know, on the unit that you're doing it. So we invite everyone to come together, and because it's really interesting, you're really doing some amazing work. We want to publicise that. We want to make sure that that's being celebrated. And finally, your leadership development. So these are 4 key modules that we will provide. There may be more on top of this, though. It just depends every year on availability. So authentic leadership, that is about leading self. So what are your skills? What are your behaviours? And how do you, what are your strengths? How do you harness those strengths? How do you, you know, really improve a whole range of, and become confident in using a whole range of your strengths. Polished presentation, so that's training you to do what I'm doing here, presenting to an audience, whether that's virtually or whether that's face-to-face, and we run that just before your mid-project presentations. So you'll have those skills, so you'll be confident when you stand up in front of that audience. We run mindfulness training, and we run this because during this program, but also during sort of your day-to-day working life, it's easy to get caught up in the next thing you have to do, the next thing you have to do, and that can be very stressful. So mindfulness is about bringing you back to the present and helping you manage that stress. So we want to give you the key skills on how to do that. And peer support training. So this is a new program that we're going to be launching next year, and it's to develop you and enable you to support your peers in times of stress and times of distress. So if at the moment we know that there's, you know, quite a lot of stress out there amongst clinicians and amongst our peers, and so we want to enable you to have the conversations to help support them. And, you know, if you are approached, if you're in a mentoring role or if you're in an educational role, we want you to be able to start those conversations and have those conversations confidently. So now I want to hand you over to a participant of the program, Isabel. Isabel did her project this year at Midland. Poor Isabel sort of program started right smack bang in the middle of COVID, but it is amazing to see what she has achieved, given it was a challenging time and everyone was sort of worked pretty hard. So I'm really interested to see Isabel's project. I haven't seen it yet. So without further ado, I'll hand you over to Isabel. Thank you, Isabel.
Hi everyone, I'm Isabel. I just finished my service improvement post, and I'm going to talk to you all about it today, as it is at Midland Hospital. I'm just going to share my screen. So the name of my project is Tracking the Pulse. The project was focusing on chest pain patients presenting to Midland Emergency Department. So why I applied initially? So I applied in order to try and find solutions to problems that bother us all in hospitals, such as bed blocking, inefficient systems, delays in discharge, and try and experience leadership in a different context. I got quite frustrated working clinically after a few years with sort of the attitude of we've always done it this way, and sort of the policies, the pathways, and the sort of resistance that we all face as junior doctors and clinical staff in the hospitals. And I wanted to learn to really change things in a really sustainable way. I also wanted to experience leadership in a different context, and also experience all the professional development workshops that we offer, that the Service Improvement Post offers. And I also wanted to try the non-clinical life. Lots of shift work can really affect work-life balance. I thought I'd just see what it was about. The Service Redesign focuses quite a lot on a change from a fixed to a growth mindset. So fixed mindset is generally, we've always done it this way, difficulty responding to feedback, stuck in old traditional ways. Whereas a growth mindset is sort of looking at things from a different point of view, trying new things, being challenged, and trying to make sustainable changes. The aim of my project was to streamline low-risk chest pain patients to the emergency short stay department in our Midland Hospital and try and reduce their length of stay. The DMAIC cycle is something that Esther's talked about, and this sort of provides a structure for the project. So initially defining the problem, measuring what the actual problem areas are and quantifying it, analysing why there's a problem and finding the root causes, trying to improve the problem, and then establishing ways of creating sustainability and reevaluating possible solutions. My problem was that at the, over 3,000 patients presented to Midland Emergency Department over a 6-month period in 2019. That's a lot of patients. Over 400 were admitted to the Emergency Department short stay unit, about 13%. And their average length of stay was about 10 hours, which is a really long time. The hospital guideline outlines a maximum of 5-hour stay, so that's a really prolonged length of stay. And obviously all the things that come with a prolonged length of stay, such as an increased cost of delivering healthcare, reduced satisfaction, and bed blocking, which is quite frustrating for everyone involved, including patients. This shows the process map. So this is part of the define area of the DMAIC methodology. 16 stakeholders attended my session: doctors, nurses, allied health staff, clerks, and PCAs, and we drew out the journey from patient triage to discharge from the short stay unit. The main areas of problems found were actually the bed requests and the review by a doctor in short stay for discharge. And this sort of, lots of the problems that were expressed by the stakeholders focus in these areas. This actually shows the process map in detail. You will learn to use Visio on your service improvement post, and you will learn how to use colourful boxes and to give all the different people involved in the process different sort of shapes and colours. As you can see, it's a very complicated process, but you will learn to do this. So there's no, you don't need to worry about this at the moment. From my process map, there were 48 problematic points that came up. Clusters of issues focused around the patient getting the chest x-ray, bed request for the short stay unit, and the review by the senior doctor. So that's quite a lot of problems. So moving on from the define stage of the DMAIC methodology, I started collecting data in order to actually quantify what these problems were. I'm not going to talk about all my data, just the important points. And just wanted to show you that the mean length of stay in the emergency department is almost 3 hours, and the length of stay in the short stay unit is an added almost 4 hours, which creates a total of 6.5 hours average length of stay. This is different to the original 10 hours, and this is because I focus on the 40 patients in detail rather than the large group of patients. The next slide shows you all the data that I collected in a summary. So I measured all the different steps of the process to determine what the real delays were. As you can see, the chest x-ray is actually done within 1 hour, and it doesn't affect the length of stay. Blood tests were taken pretty much on time. The main problem was actually the time from the final blood test until discharge, and this was 2 hours on average, which is quite a big delay where the patient is just sitting there and sort of just waiting around. Following the data collection, I moved on to the root cause analysis. So root cause analysis is actually defining what the problem is and why it occurs. So looking at the underlying causes, the contributing factors, and in this case, why is there a 2-hour delay from the time of blood test until discharge of the patient? I had a root cause analysis session with all my stakeholders. We analysed and talked about why this is occurring, and all the stakeholders contributed with their ideas. This is sort of the outcome, again, using Visio, of what the stakeholders were concerned about, and the red dots signify the votes from the stakeholders as to what they feel was most important. As you can see, the most important things are leadership, structure, and communication. Just to mention a point here, in order to facilitate these sessions, you don't actually need to be part of the hospital, the specialty, or the department. It can be a completely different area. The service improvement post will teach you this facilitation skills required, and the stakeholders will actually come up with all the ideas. So you don't need to remain in the area of work that you are at the moment. It is possible for you to work in other areas as long as you sort of attend the training and learn the skills. So just moving on, communication and leadership, they're two really important issues. They come up a lot in healthcare and in other areas. They're the biggest complaints from patients regarding problems faced in the hospital. And they're really difficult to quantify, and they're also really difficult to teach. So breakdown of these is often the first time they're actually noticed. So working in a toxic environment that's dysfunctional, poor communication, and poor leadership, people will often notice it. Whereas actually when they're really good, people seem to notice it a bit less. As I was saying, these are problematic, difficult to quantify, and patients complain about them a lot, and understandably, and they often lead to significant errors in practice. Following the root cause analysis session, I had a solution generation session, and at this point I moved on to the improve section of the DMAIC methodology. This shows my solution generation session. So in the photo, you can see an ED consultant, one of the ED clerks, and one of the nurses, all trying to brainstorm ideas as to what we can do to improve the problem. Initially, we had a bit of a fun activity with an icebreaker, and on the right side, you can see one of the ideas for a survival tool for camping for myself. For some reason, they all had champagne involved. I'm not sure why. So from the solution generation session, the main things to take away is thinking outside the box, innovative ideas, assigning responsibility to people that could also be involved in discharging the patient, and don't necessarily have to stick to the traditional roles of working in silos, that it always has to be the doctor that discharges the patient. These are just a couple of quick wins, so quick solutions that I implemented in order to improve communication. So due to the frequent rotation of doctors, the nursing staff in the short stay unit find it difficult to know the doctors, and they also don't work many shifts there. So I created a short stay doctor of the day poster, where every day the doctor would put their photo up with their name, and it would help with easy identification. And I also created laminated password badges for the nursing staff in order to also be able to access results. This will sort of empower them and enable them to be part of the discharge procedure rather than just be the traditional role of the doctor being involved. The main solution, however, which is currently under progress, is criteria-led discharge. So this would involve the patients having certain criteria set in the main department, and then if they are met in the ED short stay, they can then be discharged without a review by the senior doctor, either registrar or consultant, while they're in there. Because as we saw earlier, that contributed to the largest delay while the patient was waiting. This would allow all team members to be involved in the discharge, empower the nursing staff and the junior medical staff, and step away from the traditional roles. The planning meeting is in September, which is very exciting, and I have been in contact with some other hospitals in Perth, as well as New South Wales and clinical innovation units, because they use the criteria discharge. So I wanted to get some ideas and advice from them. You don't need to reinvent the wheel with your solutions. If someone has already implemented it, it's fine to help use their help and advice in order to implement your solution. And we also did a literature review to determine what evidence is currently out there. Towards the end of my project, I wasn't able to complete the implementation of the solution. So I created a handover document to the heads of department and the ED consultant with methods in order to evaluate the solutions and promote sustainability. As I said, it's unlikely that you will implement solutions. If you do, that's great, but it's not necessarily expected due to the short duration of the projects. The important bit is to learn the skills which will be able to be used in any department or country or specialty in the world. And the important bit is also to familiarize with yourself with the DMAIC procedure and how to actually undergo the project. Obviously, implementing solutions is amazing and it's really encouraged, but don't get disheartened if you're not able to actually implement it, as long as there's some sustainability involved in a handover document. So what I learned, this is actually one of the best things I've ever done in medicine. It really taught me how to think of healthcare as a whole system rather than just the individual 10 or 20 patients that we see on a daily basis. Healthcare is really complex. Like any other industry, it takes a long time to fix things rather than just adding another form or adding another tick box exercise. It actually takes time to create sustainable solutions, find what the root causes are, and then be able to fix them. I also learned that leadership can take many forms rather than just the traditional roles that we see in clinical practice. I also learned that people you work with have really interesting backgrounds. Lots of the clerks in my hospital that I didn't really get to chat to that much during clinical work have really interesting backgrounds. They're awesome with Excel, which I've learned I'm not amazing at, something to improve on. And they have invaluable skills, which often when not known to us when we just work clinically. So it's really good to just get chatting to people, get to know people, find out what their strengths are. Why should you apply? So firstly, you learn how to truly become a leader in the context of clinical, non-clinical, in any specialty or department. You get to experience clinical redesign firsthand and how to actually improve the problems that we all complain about all day. You also get to meet the people that are involved in changing these problems and improving them and what they actually do to help us, because it often feels in clinical practice that we get neglected, no one cares about our department, no one's making any changes, but there are lots of reasons behind what change to prioritize, and you really get to see why this happens. You also get to see healthcare from a different angle and learn about the different things in the system that impact patients on a greater scale. The professional development workshops are also great. You get to really improve your CV and also learn lots of different things that you might not be able to usually in the clinical practice. The project will also open doors for future careers in management and clinical service redesign. Even if it's something you don't end up following, it's really good to get a taste of it to see if it's actually something you want to use in the future. I just wanted to say thank you to all these people who helped me throughout my project. As you can see, it's a wide variety of job descriptions, where they work, what their roles are, and everyone has been really helpful, and you get to meet lots of interesting people during your project. If you have any questions, feel free to email me or email Esther. This cartoon really describes some of the days on my project where I had lots of problems, lots of things to solve. I put them all on a spreadsheet. I was still a bit lost. There will be days like this, and that's okay. It's quite different getting used to a non-clinical post, but actually there's lots and lots of people out there support you. You have lots of supervisors. Esther is great. So if you do have any problems or questions, there's always someone there to help. I would really recommend you apply, and good luck.
Thank you so much, Izzy. That was
welcome.
It's brilliant, really, to see what you've achieved over what is relatively short period of time. You've really made a really big dent and a really big improvement in your project, and it's also great to hear that you enjoyed the rotation, which is what we always like to hear. And I think for everyone here, it's a great example of what you can get out of the project, and as you were saying, it doesn't necessarily have to be in an area that you've worked before. It could be even in a hospital that you've worked before. It really is about learning the skills and making the improvement, and you will pretty much be passionate by the end of it about whatever you're working on. Izzy, I'll just get you to turn your screen off as well. We've done practice, and if anyone has their screen on, it doesn't sort of show up properly. So what I will do, I'm not sure if Seb is here yet. Seb was ducking out of work early, and so I'm hoping he has been able to join us. Actually, I do see his name.
Hey, boss.
Hello, how are you?
Yeah, good.
Good. Now, I'll get you, if it's all right, to turn your video on. Are you happy to share your screen with us as well?
I am going to try.
Okay,
So,
wonderful.
I am still at work, so I'm on the mobile app, and I don't know if it's going to allow me. No, I don't think I've got that option, but I'm happy to have a quick chat if
Okay, yeah,
you
if you
still
want to
want me
talk us through, otherwise if you can email me anything, I can share my screen, whatever's easiest. But if you're happy to just tell us.
Oh, maybe I'll just have a quick chat if
Yeah, perfect. I'll hand over to you, Seb. Okay, I think we're having some technical difficulties with Seb's connection.
bothered by me sitting and talking. So, hi guys, my name's Seth, and I completed the MSI, and I essentially signed up for. Are you able to hear me, Esther, or is it a bit choppy?
I can now. I think it's caught up.
All right. So, sorry guys. I signed up for the MSI last year, essentially hoping to look at problems from a systemic point of view, and just a little bit disenfranchised with junior medicine and always following the leader and not really instigating much change. And so I just wanted to look at things through a different perspective. And for me, I certainly found that the MSI allowed that, and I was pretty grateful for it. So I actually chose to do my project in an area of interest. I want to and hope to be in ophthalmology, and so I chose to stay within that specialty for my service improvement program. And essentially, I went to the head of department and asked if they had a problem that they wanted to fix, and if I could do my MSI within the department to help fix that problem. We ended up finding one, which was that the business unit from the hospital had been quite worried about the over-boundary list for outpatients, particularly in glaucoma. And so my project focused on the glaucoma pathway for outpatients and how long people were taking to get their follow-up appointments. The specifics of the project were quite interesting because as someone interested in that area, I actually got to learn quite a lot about both the pathology and the management system for how we manage an outpatient clinic. And I thought that, especially from like a future career perspective, that was pretty valuable knowledge. From a program perspective, I just found that learning about project management and specifically learning about Six Sigma and Lean principles was just so useful. It was nice to be a bit of a student again and to really be learning skills that I thought would be valuable in the future. And so I followed the program. I certainly drank the Kool-Aid and enjoyed learning from Esther and I was at Royal Perth, so also learning from Schumett and Catherine. And I still touch base with those people pretty regularly as mentors and people I go to for advice, especially in the medical administration and change management world. But yeah, my project was somewhat successful. I certainly thought that from a project point of view, we were able to implement some medium and some immediate solutions, which actually changed the way the clinic operates. And we introduced a new model of care in the clinic, which was an Australia first, which I didn't know that we were doing. But that was quite successful. And essentially it allowed for the project to be presented on a national stage. And so from a CV point of view, if anyone looking at the program is sort of looking at it with that perspective, it's nice to be able to put in some sort of clinical safety and quality measures on your CV that you've done a formal program and that you've participated in some of these events. And then again, from a CV point of view, for those of you that are that way inclined, having conference presentations and having something real to talk about at a conference rather than a poster was actually quite nice, and certainly in some ways I think helps. The immediate and medium solutions, like I say, have made a difference. Unfortunately, due to COVID, we weren't able to measure the long-term effect of that difference. So I think the academic application of it will probably stop there. I'm not sure that I'll get publications or further presentations from that side of things. But I guess more important than that would be the personal side of the skills I learned on the program and the conferences that we got to attend and the workshops. All of those things are now strategies that I employ almost every day, especially in an ED context, of how we can improve patient care, but also how we manage conflict and how we manage stakeholders and different personality types. So for all of those reasons, I'm a pretty strong advocate of the Medical Service Improvement Program. I think it certainly changed the way I think about medicine and about my career. And while it was always something that I was interested in, it's certainly now something I'm pretty passionate about. So Esther, without any slides, I might keep it short and sweet and just see if there are any questions.
Thank you, Seb. That's great. We might just leave some questions until the end. If you've got any questions, email them through to me and maybe I can pass them on to Seb. Just because we are running short of time. We have 10 minutes left and I really want to tell you how to apply and some of the information about what we're looking for in applicants. But a big thank you to Seb and to Izzy for sharing your knowledge and your experience and also about your project as well. As you can see, both participants sort of made some really great improvements in their hospital sites and in their selected areas with all the additional sort of benefits. So thank you both. Now I'll just share my screen with you again and we can go through some of those how to apply questions because applications open on Monday, on the 24th, next Monday. So sorry, just 2 seconds. All right. So selection process, CSI selection process. There's a written application. So the written application is for medical staff. It is via MedJobs. For nursing, midwifery and allied health staff, it is via a written application, which is on our website, and then email it to the email address on our website. After that, there is a panel interview. And that panel interview has a representative from your hospital, a past participant of the Medical Service Improvement Program, a discipline rep, and myself. And finally, should you be shortlisted for interview and selected for the program, we will then let you know and negotiate with the various workforces to coordinate your being put onto this program. So a bit more detail. Applications are open Monday the 24th to the 21st of September. There are a number of sites, so Charles Gardner Osborne Park, Royal Perth, Women and Newborn and Rockingham, who are running an internal EOI process at a later date for nursing, midwifery and allied health staff. Because it's an inaugural pilot year, obviously the processes aren't quite in place for getting these participant or these positions established. So we're just taking a bit more time for these areas just to do the background work on it. But you will be informed by your sites when those applications open. It's the exact same process, it's just not happening on Monday. If you need any further information about that, send me an email or go to the website and there's further information. As I said, how to apply, MedJobs if you're medical, and all medical applications open on Monday. And nursing and midwifery, look at our website, get the application package, fill it in along with your CV and email it to us. So what are we looking for in applicants? We really want to hear about you. That's obvious, but we want to know what motivates you. Where do you see your career heading? What experiences do you have that can help demonstrate some of the skills that we're looking for and all of the things that I've just spoken about? So really use examples, be succinct. And if you haven't looked it up and don't know it, look up the STAR approach, Google it. That's how we want to see your answers. It's the way to answer selection criteria, and it's really, really example based. And do your research. You know, we can tell if you've done your research and you know what you're applying for. For interviews, Interviews will be between the 12th of October and the 23rd of October, 2-week period. You'll be informed if you're shortlisted in late September, and then interviews will be at your hospital site, either via VC or in person. And as I said, there's an interview panel. They're 20 minutes in length, and if you are selected for the program, we'll let you know in late October, early November, and we can start that workforce negotiation at that point. Again, tell us what motivates you, where you want to go with your career. Give us examples, and think about that why of CSI that I referred to on previous slides. So, and how does this relate to you? So when you're thinking about your examples, when you're answering your selection criteria, when you're doing your interview, there's 4 common themes, and they've come out throughout this whole sort of presentation today: leadership, communication, service improvement, and sustainability in healthcare. That's what this whole program is about. So that's what we want to ask you about, and that's what we want to hear about. So are you eligible? This is up on our website, but to be eligible for the program, you must have 12 months minimum postgraduate clinical experience in a public health system as a nurse, midwife, RMO, or registrar or allied health professional when you're commencing the program. So that is as of the start of next year. If you're a nurse or midwife, you will need to sort of be that clinical nurse level 2 with a maximum of 2 years experience in that role, or you're looking to step into that role in sort of the next 6 months. And everyone needs to be contracted to work clinically at a participating hospital that is offering a rotation or a position with your discipline. And the reason for that is because this isn't a role. We're not recruiting you for a job, we're recruiting you for a program. So we need you to have a job that we can then second you out of. And you need current professional registration to practice clinically in your field. So if you meet those requirements, then wonderful, we'd love to see your application. If not, 2022 is looking great. But give us a call if you're a bit iffy about the eligibility criteria or have further questions. Send us an email and we can let you know. And if I need to double check sort of with the sites, then I can do so. Again, participating sites are here. I won't go through them all because we've already sort of done that. Applications open Monday. Look out for this poster. It's going to be stuck up, it's not yet, but it's going to be stuck up everywhere all over the system, with further details on the website. But are there any questions? Does anyone have any questions very briefly in the last sort of 4 or 5 minutes? If you do, maybe put them in the chat function, and then what I can do is I can look at that and I'll just talk to that.
See you tomorrow morning. See you to petition. What's happening?
All right. If there are no questions, I will wrap it up there.
It's Esther.
Here we go.
It's Alex here.
Yes. Hi.
We got a few questions. There's one that was sent through earlier from Anne Stored.
Sure.
She said, why 1.4 FTE for CARS nursing? Does that mean you may only undertake the project part-time?
Okay, so at CARS for nursing, because of backfill and staffing sort of issues, because they are having to backfill and all of that, it is at a 0.4, but it's 2 positions at 0.4. So there's one position that goes sort of from April through to I think July, and then there's one that sort of goes I think from June through October, I think. So there's 2.4 positions over a longer period of time. So it's not full-time 10 weeks, it's part-time or just under part-time for 2 rotations. Hope that answers your question. Do you need a project already in mind for the application? That's David. You don't, no. So that it's absolutely fine if you don't have any idea of a project you want to do. What we do with project selection, each site is slightly different. Some sites, you come to them with a project and then they 9 times out of 10 will say, great, yes, that sounds good. Most sites, you might have some ideas, they have a list of projects, and then you work together to find a mutually sort of agreeable project. And that's often a very good way of doing it, because the project's going to have strategic backing, it's going to be in line with the strategic direction of the hospital, but it's also going to be something hopefully that you're quite passionate about or that interests you. So don't worry if you don't have a project. Okay, one from Prue. Many early career employees in allied healthcare on 6-month rolling contracts. How does this affect eligibility? So if you have a contract for 6 months, say at the start of 2021, then you're eligible. It doesn't need to be for the full year. If you're hoping you'll have a contract for the start of 2021 because you're currently on a 6-month contract now and you assume it'll roll over, still apply. If you, at the end, what we do closer to the end of shortlisting or at the end of application submission, we go to the various discipline workforces and just verify that you will be employed next year. So, so we can wait till you can apply in the hope that in the next couple of months that rolling contract will be confirmed. But obviously each person's going to have slightly different workforce and contractual arrangements, so we can hopefully work with you on that. Okay, just confirming you need minimum 1 year RMO experience, not 1 year JMO, including intern. If you're an intern this year, you can apply for the program next year. So PGY2 and above. Okay, sorry, what else? How many positions are offered? It depends on site. So I think next year we have 40 positions total, but that's, you apply for your site, not for all 40 positions. So if you're working at Royal Perth, oh no, that's a bad example because I haven't confirmed yet. If you're working at PCH, and you're an allied health or nursing staff, then you go in a pool for 2 positions. If you're a medical staff at CARS, then you go in the pool for 4 positions. So you will go up again, you will be assessed against your discipline at your site for a particular number of positions. How do I assess if a project idea is unrealistic? If you get into the program and we look at project ideas, the way you will work with a supervisor to select a project. So they will be able to tell you too big a scope, not the right type of project for this, that doesn't really have strategic backing or all of those things. They'll help you nut that out. So you won't need to do that alone. And as I said, if you don't have a project idea, that's fine. All right. So I think that's everyone's end of everyone's answers. So a big thank you. Thank you all for coming along today. This recording will be put up online tomorrow, and that will be on the website for the whole application period. So if you need to refer back to it, you can certainly do that. But a big thank you to our presenters and to Alex, who helped me facilitate, who's my colleague at the Institute for Health Leadership. And I look forward to reading all your applications in the coming months. So a big thank you and have a lovely evening.